to request Dr. Anand Rajendran to give his talk on the real uses of OCTA in AMD.
Thank you, Manoj and Uni, for having me in this IC. It's a pleasure to be here this morning and to talk to you on the real use of OCT angiography in AMD. Now, the 3 or 4 musketeers or investigative modalities that serve AMD are FFA and ICG. These are the invasive ones, OCT, and the new kid on the block, OCT angiography, which are non-invasive. Now, the rationale for OCTA, OCT angiography in AMD, we can look at the comparative merits of the investigative modalities available. FFA is the gold standard for diagnosis and classification of CNVMs. This used to be the case, and now with anti-VEGF therapy, that is getting blurred a bit. ICG helps delineate the entire extent of lesion and distinguish it from PCV, where it really finds its USP. OCT is great for structural imaging of the thickness, fluid compartments, PEDs, and qualitative and quantitative assessment. But it is really OCT angiography where you can pick out these early small neovascular sprouts and the early progenitors are highlighted or delineated very well. Whereas with conventional fluorescent angiography, these are often concealed by the late phase hyperfluorescence. It hinders precise characterization of the vascular features, and of course, there's always the issue of anaphylaxis. So what are the principles of OCTA? OCTA provides a clear, depth-resolved, dye-less visualization of the retinal and choroidal microvasculature. It's based on the principles of motion contrast imaging. RBC movement is mapped over time by comparing sequential OCTB scans at co-registered point locations. Now, there are different algorithms out there, the OMAG, which is very effective in the Zeiss machine, optical microangiography, SADA, which is used by RTView, split spectrum amplitude decorrelation angiography, and then you have FSADA, which is full spectrum amplitude decorrelation angiography. So, OCTA and AMD enjoys the benefits of a good diagnostic, which is a good predictor and a good prognosticator, and we'll look at that. So, detection of neovascularization in AMD and PCV is based on boundary-specific segmentation. This is basically different segmentation strategies used based on location of the neovascularization. For example, outer retina to chorea capillaris, or what is becoming popularly called the ORC slab, detects all macular neovascularization. Outer retina to RPE slab detects your type 2 neovascularization, or erstwhile classic CNVMs. And RPE to chorea capillaris slab below detects type 1 neovascularization and PCV. So you can see this is the RPE segment, and this is the RPE fit, or the Brooks membrane. So to optimize visualization of CNV or PCV and minimize projection artifacts, one can either change the thickness of the RPE fit slab, or can change the position of the RPE fit slab. Now, predictive features of using OCTA for neovascular AMD. This was given by a very recent, very good article by Choi et al., who looked at type 1 CNV in neovascular AMD and subjected these patients to loading days of aflibercept and then PR and thereafter. They then segregated the patients into 2, those that were stable, who required only less than 2 injections in the follow-up period after loading dose, and the unstable patients who required more than 3 injections. And they looked at quantitative features. And in that, they compared a number, neovascular area, length, density, lacularity, which was a sprouting tendency, endpoint density, which is the number of open-ended vessels per unit length, junction density, which is the number of junctions per unit length, and largest vessel caliber. And then they used various angio-tool-based software analytics. And they came up with this big table where they segregated the findings into the stable and the unstable group. What they did find was that there were 2 parameters, endpoint density and lacunarity, which was increased in the unstable group with a significant p-value. And they then developed a predictive model based on the endpoint density, which had very high sensitivity and specificity. Now, these findings were based on a primer erstwhile article by Koskas et al., who looked at this initially, and they looked at a large number of patients, 126 AMD CNVM eyes. And they used Spectralis Heidelberg for the structural OCT and OCTA of the top con, and they detect these 4 OCT angiographic morphological features initially. The tiny branching vessels, which are thin tangled capillaries, followed by vascular loops, which are peripheral connections of these tiny branching vessels. Both these were in the high 80s, followed by peripheral anastomotic arcades, which are inner anastomosis between these very same tiny vessels, followed by choriocapillaris hypointense halos, which are hypointense zones suggesting choroidal low floaters. Next. So then they found that the summation of all these 4 give the highest predictive value for exudative activity and the need for anti-VEGF treatments up in the 98%. The most reliable ones were the 2 ones which were highest, tiny branching vessels and vascular loops, which had the highest correlation with the treatment decision and the highest relative risk of exudation. So these were the tiny branching vessels, peripheral anastomotic arcades. Now, courtesy Dr. Phil Rosenfeld, he has been able to use the swept source Plexilite 9000 with a high number of A scans, 100,000 A scans per second. And we've been able to really look at the two components of the mixed or composite MNV. As some examples here, beautiful examples. And here in this page is put up the NFAS OCT, followed by the NFAS structure, OCT slab, and the structural OCT. So you can see various examples where they've been beautifully been able to differentiate the two components. So this is, here you have one where the type 1 MNV is sitting atop the type 2 MNV, another where the type 1 and type 2 are on either side of the MNV. So when a CNV is actually refractory, you can actually make out which component is causing that refractoriness and which component is actually melting away. So OCTA is also very useful in RAP lesions, as you can see here. This is OCTA for RAP lesion here, and you can see the magnified OCTA, and these actually look better than what you see on the FFA. Another case of a RAP, you can follow it post-treatment. You can see that neovascular network just melting away post-avlibicept. So it's a very good tool for monitoring treatment too. Another case where a RAP lesion, where you can see then in the OX lab, you can see that on-fuzz angio with the projection artifacts, and then the lower OR RP slab, when you bring that slab down, you can see that's the same thing with a greater detail. But then once you remove these projection artifacts, you can actually see these beautifully highlighted, and you can actually really track that neovascular network going forwards. In PCV also, it's beginning to show this thing. You can see the polyp and the double layer sign on the OCT, structural OCT. On the OX lag, you can see the NFAS angio once projection artifact removed, and you can actually see that network quite beautifully. But when you go forward with the RPCC slab, you can actually see it even better with the polyp, with the tangled vessels within that, and the branch vascular network. And in fact, this looks a lot better, in fact, than what you see on FFA ICG, where you see the polyps and the BVN actually structurally standing out beautifully. SD-OCTA is also able to uncover CNV where you have an elevated type 2 MNV, and you can pick up the CNV complex. Now, this is a very interesting article which also came out by Henrik Farts et al., who looked at monitoring AMD activity. They used OCTA to develop a mathematical model. Okay, and they used the vascular parameters, CNV, area of CNV, total length of all CNV vessels, overall number of vascular segments, and fractal dimensions. And they used this to create a mathematical hologram, which you see on the upper part of the panel. In this one particular case where, for example, you see a cyclic regression and recurrence. And what they did is in this hologram, they were able to pick out those early neovascular sprouts, and they correlated those sprouts emerging and regressing, and it correlated beautifully with the cyclic recurrence and regression pattern. So we will hear more of this as work is being done on these mathematical modeling. But as of now, one of the marquee and recognized uses of OCTA in AMD is this subclinical neovascularization in non-exudative AMD, with beautiful study brought out by Dias et al. From Dr. Phil Rosenfeld's group, where they looked at 160 eyes, 110 intermediate AMD, 50 GA, and they found that 23 of these 160, or 14.4%, had high incidence of this subclinical CNV. And 10 out of these 13 eyes had prior detected subclinical CNVM on the swept source OCTA. And so basically, eyes with subclinical CNVM going on to clinical CM were 21%, whereas eyes without subclinical CNVM going on to clinical CM were only 3.6%. That gave a very high prediction value. About after detection of subclinical value, the risk of clinical CNVM is 15.2 times more than eyes that didn't have the subclinical CNVM. So this is another example from that series where you have structural OCT at 1 and 2 different levels, and you see that there's this intermediate AMD sitting quietly there, quiescent, asymptomatic, but below that, below the RP, you see this creepy crawly neovascular subclinical network growing continuously, 4 months, 14 months, up to 21 months, and then suddenly at 2 months, we do not know what the trigger is. That's the issue here. We do not know what the trigger is, but suddenly out of the blue, some fluid starts appearing, patient is still asymptomatic, anti-VEGF was suggested, did not go ahead. And then a month later, you see it suddenly explodes, and then patient becomes symptomatic, was given anti-VEGF as a treatment. So there are limitations of OCTA which we recognize: large PEDs, subretinal macular hemorrhage, severe pigmentation, severe scarring in gloves. All this will obfuscate the picture and limit the use of OCTA. So in summary, OCTA's utility is definitely going to be there, and is going to keep exploding and increasing in AMD with advances in OCTA. Dye-based angiography may no longer be needed for neovascular AMD. For predictive value, detecting subclinical CNV, as I mentioned, in non-neovascular AMD, tailoring follow-up. Once you see that network there, you can, make the patient come more frequently. It can predict early strikes for subclinical MNV. Once we detect these predictors a little better, early predictors for exudative activity, like you mentioned, tiny branching and vascular loops, differentiating the types of MNV as I've shown, and staging or characterizing RAP lesions. It can give us an early citer, an early detection of this recurrent network, and SSOCT is going to play a greater role in detecting type 1 MNV and PCV specifically. Thank you.
Thank you, Dr. Anand, for that lucid talk. Any queries? We'll take a few questions now. Anand, I have a question for you. Do you think that OCT angiography can actually replace conventional angiography in PCV? Like I'm giving you a situation, PCV.
Yeah, so I think so what has been shown is that with the newer developments in swept source OCT, basically if you have to do that, you have to hone in, zoom in on that RP choriocapillaris slab. And everybody believes that the choriocapillaris is going to be the next big thing in macular imaging. And swept source OCT is doing a great job. What I showed you were images with 100,000 A scans per second. Now Plexelite is coming out, and more other companies are also coming out with faster machines with better noise removal, projection artifact removal. And as I showed you, those networks are actually seen better. So if the media is reasonably clear, it'll probably encroach in that territory, and we might see greater ubiquitous use of OCTA for PCV also. But it'll have to be, I guess, with swept source OCT rather than NST.
Now, how good is OCTA for detection of polyps? That's because BVNs, I understand it's good enough.
Yes.
But for detection of polyps, it's not OCTA poor in picking up polyps.
Yes, as of now, no. As of now, because one thing is this Plexelite is not universally available. All those images were only exclusively Plexelite images, where you have that depth, it images at that deep depth. So that is very critical. Also, we have to remember that unlike BVN, which is largely uniplanar, polyps are multiplanar. So it has to be able to detect and segment at that different levels. But the new Plexelite versions are coming out with 200,000 A scans. So there it is becoming even more easier to pick out these multiplanar things at that depth. So yes, the answer is futuristic going forwards, possibly yes.
Thank you.